Good afternoon, everybody, or I guess good evening. My name is Sean Morrison, and I have the honor and privilege of chairing the Brookdale Department of Geriatrics and Palliative Medicine. And I'd like to welcome all of you to our annual Douglas West Endowed Memorial Lecture. And this evening, I'm delighted to be introducing my friend and colleague, Dr. Kimberly Johnson, to all of you as our 27th West Lecturer. First, however, I'd like to extend my real profound gratitude to Susie West and the entire West family for endowing this renowned lecture series in Doug's memory and in honor of his physician, Dr. Diane Meyer. Susie's been a volunteer, board member, board chair, and palliative care champion for the Lillian and Benjamin Hertzberg Palliative Care Institute and the Center to Advance Palliative Care for over 2 decades. It's really impossible to calculate her contributions to the field of palliative care and to the number of lives that we have touched because of her dedication. Thank you so much, Susie. I'd also like to thank our Hertzberg Advisory Board, and particularly its current chairs, Saskia Sidorow and Meryl Rosofsky. I'm so grateful to the board for helping to anchor our department's work to the needs of patients and families, and for their tremendous support of the work that we do. I think if one were to look at the greatest ethical issue that we were facing in the United States right now, and in healthcare in the United States, it would be the inequities in the care that's delivered to our citizens and to the entire population. If there was ever any doubt as to whether it mattered what you looked like, where you lived, what your background was, what your income was in terms of the care that you received and the outcomes of that care, COVID laid that bare. It is simply a fact that if you don't look like somebody like me, your access to healthcare is different, that is reduced, and the outcomes that you can expect are suboptimal. It is simply now a fact. And no number of excuses, no number of studies, no comparing this to that changes that fact. And our speaker tonight has dedicated her career to changing that. Kimberly Johnson is, simply put, the international leader in geriatrics, palliative care, and health equity. There is nobody in the field who has her expertise. She's a professor with tenure at Duke University Medical Center in Durham, North Carolina. She's the director of the Duke Center for Research to Advance Healthcare Equity, also known as REACH Equity, which is one of NIH's specialized research centers of excellence on minority health and health disparities. And the center focuses on developing and testing interventions to reduce racial and ethnic disparities in health, particularly by improving the quality of patient-centered care in our clinical encounters. I first met Kimberly, I think, over 20 years ago, when she applied for and was one of the first NPCRC Kornfeld Career Development awardees. And I have just watched her career take off like a meteor. I have watched the contribution she has made to our field, the science she has done, the number of early stage scientists that she has mentored and developed, and her ongoing incredible commitment to ensuring that everybody in this country has equitable access to high quality geriatric and palliative care. I can't think of a better person to speak to us on this issue. She has, for 2 decades, tackled probably the most challenging problem, and as I said, the greatest ethical issue in healthcare in this country. And I'm delighted that she's going to join us today. After her presentation, we will have time for questions from the audience, and please be sure to submit those through Zoom, and I will feed them to Dr. Johnson. And please join me in welcoming her to the 27th Douglas West Memorial Lecture. Thank you, Dr. Johnson.
Well, good evening. It's great to really have the opportunity to speak to you this evening in this memorial lecture. I really am honored. And I was a little bit scared when Sean said we had known each other for 20 years, because that tells you something about my age. So just to get started here, if I can advance my slides, we just practiced this. Let's see. Here we go. These are my disclosures for the evening, recognizing that for many of you, I'm the only thing standing between you and dinner, and you're the only thing standing between me and my dinner. I really want to focus on three broad areas. For context, I really want to talk about inequities in healthcare for Black Americans in general. Quite frequently, I start my talk off often talking about inequities in the experience of Black persons with serious illness. And as I started preparing this talk, I really thought about the fact that I'm really starting at a place where much of the groundwork for which I talk about has already been laid. And so in this talk, I'm actually going to start a bit at the beginning and proceed forward. After I talk about those inequities in serious illness care, I'm going to talk about research approaches, both specifically focused on health disparities research and then research in palliative care in general, and potential opportunities to move the field forward. So for those of you who, like me, maybe are fans of the music of Michael Jackson, you probably got my riff on Michael Jackson's 1991 hit, It Don't Matter If You're Black or White. In fact, I can even today, frequently find myself dancing or bopping to that in my car. And I've often wondered, what is it that Michael Jackson meant? Particularly given that I've made much of my career really talking about and committed to raising awareness of the fact that it does matter if you're Black and white and how that affects serious illness care. And so near the end, I'm actually going to return and dig a little bit deeper into the message from this song and really how it might resonate as we move forward. So as I said, I'm really going to start at the beginning and argue that really it matters if you're Black or white from the very beginning. And by very beginning, I mean for women who are expecting. So we know that maternal mortality, it matters if you're Black or white when you're pregnant. If you look at differences in maternal deaths per 100,000 live births, you can see that for Black women, rates are over 2 times as high as they are for white women. And frequently people will ask me, well, isn't everything that you talk about or a lot of what we see in terms of racial differences really related to socioeconomic status? And so I add this really to remind us that there's something about race that matters over and above socioeconomic status. If you look at that red arrow, you see maternal death rates for white women with a high school diploma. And what I want you to note about that is that those rates for white women with the lowest level of education shown on this slide, that is a high school diploma, are lower than those for Black women who also have a high school diploma, but also lower than those for Black women who have some college education, and lower for those that are college graduates or above. So really beyond your socioeconomic status, there's something about race that still matters. And then at the same level of socioeconomic status, you see that Black women still do worse and often worse than women of lower socioeconomic status who are white. So if we kind of get past that stage of pregnancy, we can look at infant mortality, and that's what happens once you're born within the first year of life. And we see something very similar, that for infant mortality rates, which are often measured per 1,000 live births, if you look at Black and white, that those rates are almost twice as high for Black babies in the first year of life as they are for white babies. Again, let's think about this idea of income and how that impacts what we see with respect to infant mortality. These are data from California. California is our most populous state, and this is data over a multi-year period using large national large state-specific databases looking at infant deaths per 100,000 by race of the mother. And what they've done is they've divided this according to the mother's income, left being poor all the way to right being the richest. So if you look at the richest Black mothers, you see infant mortality rate of 437 per 100,000 live births. That rate is higher than the infant mortality rate for white women who are in the poorest segment of the analysis, so 350. So a very similar thing to what we saw for maternal mortality. The other thing to note is if you look to the right for white mothers, you see this kind of nice decrease, so that as you get wealthier, you see this nice decrease in infant mortality. So suggesting that certainly wealth is protective. You don't see that same pattern for Black women. And so you don't get the same protection if you're Black from being more educated than you see for white women. And so it also matters as you live, right? I've shown you it matters before you're born for women who are giving birth. It matters for infants in the first year of life. And then throughout life, we see this pattern. I can probably pull up any number of diagnoses or organ systems, and you see greater rates of disease, morbidity, and certainly mortality for Black compared to white individuals. I have depression, so here we're looking at psychosocial or mental health issues, asthma, end-stage renal disease, some types of cancer, stroke, cardiovascular risk factors. And it matters as you receive care. So not only do we see that Black people compared to white are more likely to have these higher rates of morbidity, higher rates of disease, but then we see lower quality health care. And so these are data, actually the most recent data hot off the press from the Commonwealth Foundation, where they look across states. And what they're looking across states at is for health system performance scores. And that score includes a combination of health outcomes related to death from preventable causes, access to health care, and quality of health care. And what's obvious, you can see white here in this blue color, and then this green is Black. Higher is better, that the health system performs better for white persons across all of the states compared to Black persons. So Black patients are faring worse across states on all these measures of health system performance. And I will just highlight one because many of you know I'm originally from the state of Mississippi. And I think that what we all know is healthcare is bad in general. So we're all the way down here in terms of health system performance. So while white patients are faring worse than across other states, you can see that Black patients are almost not on the scale, so down at the very, very bottom. There's other evidence, certainly tons that we know, suggest that there's lower quality healthcare for Black persons compared to white persons. We have the annual National Healthcare Quality and Disparities Report put out by AHRQ, which looks across 6 priority areas of healthcare quality: safety, person-centeredness, care coordination, care affordability, and healthy living. And we know that for over half of the measures, Black people receive worse quality care than white people. And if you look over time, we see very little in terms of narrowing of these differences. I will highlight, a popular or well-known report featured here, the unequal treatment from the Institute of Medicine in 2000, then called the Institute of Medicine. There's actually an unequal treatment revisited, but that certainly called attention to this difference in quality care across a number of diseases: cardiovascular disease, cancer care, HIV, end-stage renal disease, transplantation, and et cetera, and attributed it to both the makeup of the healthcare system and bias, stereotyping, and uncertainty on the part of providers. So if you're receiving poor quality healthcare, it certainly follows then that how long you live, it matters for how long you live. If we look at life expectancy for birth, and you see this decrement based on COVID and the time after COVID from 2019 all the way to 2021. And what you see is their lower life expectancy at birth for Black and white people by about 6 years. And when you look from 1999 to 2000, 2021, where people are often examining the potential impact of COVID, you see a greater drop in life expectancy for Black persons. So, what do we know about education and life expectancy? And this has changed over time. This was actually a publication in PNAS, and it uses a lot of large national data sets, death certificate data to really look at expected years of life between the ages of 25 and 74. And I think there are a number of really interesting things, many of them potentially unexpected. If you look at the group with the highest life expectancy, and I'm showing you here for men only, white men with the bachelor's degree have a higher life expectancy than any of the other groups. Black persons with no bachelor's degree have the lowest life expectancy. But if you look within education, so you can see this narrowing of the gap between white and Black persons, if you look at those with the bachelor's degree, really highlighting the importance of education here. And you also see something a little bit different from what I've shown you before, where often the most educated Black persons still are doing worse than the least educated white persons. Around a little bit before the year 2000, you saw a reversal of that, such that people who are Black with a bachelor's degree have a longer expectancy in terms of years lived between 25 and 74 than those who are white. And so these racial gaps within the same education strata are smaller, and the largest are for those who are with or without a college degree. And I think that this is really important to note, and also really to highlight the fact that Black patients are disadvantaged, or persons are disadvantaged and less likely to have a college degree. And so while we understand those things that really are drivers of health outside the healthcare system, we often see disadvantage in those areas for persons who are Black. And it still matters, right? This has been, this documentation of health disparities really can date back to 1985, really one of the first efforts by the US government to investigate health inequities with Margaret Heckler, who was the HHS secretary. And according to that report, health disparities accounted for about 60,000 excess deaths per year. Fast forward, about 25 or 35 years later, and you look at this analysis that was published looking at deaths from 2016 to 2018 in the 30 most populous cities in the United States. And you can see that they identified an excess number of deaths attributable to health disparities as over 74,000. And I will note to Sean's point that's the total deaths per year, but there's really a wide range based on where you live. And so we really see that over time, we're not narrowing, but in many instances, we see worsening disparities. So why do these inequities exist? The title of my talk, It Does Matter If You're Black or White, might suggest that really it's about race or about skin color or some phenotypic characteristics. And really, we know that it's not. And so while I've focused on race, really what I'm talking about is racism. This is from the CDC. Around the time of COVID, the CDC declared racism as a public health threat. And we know that what I've described to you really plays out in these ways, that there's systemic and structural racism that is deeply, and I emphasize deeply, embedded in our society, in systems and laws and policies and practices, written and unwritten, beliefs and attitudes. And all of those things work together to produce, condone, and perpetuate this widespread inequity that we see across systems. And all of those things ultimately impact things that we know are important drivers of health outside of the healthcare system: housing, education, wealth, employment, and healthcare. I think as we think about it, there's been this huge emphasis on structural racism. Really also want us to always remember that interpersonal racism is connected to that, really structural racism and kind of the kinds of things it perpetuates, beliefs, attitudes, and policies are very much connected to interpersonal racism, which ultimately impacts our assumptions about patients' abilities, motives, and intentions, ultimately impacting healthcare decision-making and delivery. And so we have systems to think about, and we have to think about how we operate within those systems. So now that I've kind of placed that into some context, I'm going to move quickly to this area of serious illness care. And I think that what I'll show you, if you keep the things in mind that I've shown you, the inequities that exist from beginning to end. Now we're kind of not quite at the end, but kind of hitting serious illness and going forward. And the context for those, that this makes a lot of sense and won't be particularly surprising. So, how does this matter in almost all of the domains of palliative care, or in all of them that you could think of? So I always start with pain and symptom management. We know that there's a huge body of evidence that Black Americans are undertreated for pain, and that's across diagnoses, settings of care, if you're a child or an adult, or an older person, if you're at the end of life, or with a chronic illness, or a bone trauma. We know that there is undertreatment and underassessment of pain for Black individuals. I highlight one study in particular. This was a 2016 study. I think it was shocking to people, and still shocking. It's there. Some medical students still think Black patients feel less pain than whites. It actually received quite a bit of time in the popular press. And this was a study that included medical students, residents, and interns, all of whom were white. They were asked about biological differences based on race. And they were more likely, over half of them endorsed at least one false belief about Black compared to white patients. And those beliefs included that Black patients had thicker skin, that Black patients had less sensitive nerve endings, that they had more robust immune systems. Importantly, they took the students then and presented them with two mock cases, one on an ankle fracture, the other kidney stones, and asked them to rate the pain. They were randomly assigned Black or white patient with the same story. They rated those who had greater beliefs about false beliefs about biological basis of race were more likely to rate the pain of Black patients lower and less likely to prescribe guideline-based therapies. And so we continue to really perpetuate these biological myths, which are associated with race and ultimately impact patient care. What about advanced care planning? Certainly lots of controversy associated with advanced care planning. And what I'm talking about is really this opportunity for persons, adults in particular, at any stage to share those goals, values, and goals and values which really may impact their future healthcare choices. And while there are mixed results, certainly some recent reviews by Rebecca Sidori and others have shown that there is some evidence of improvement in satisfaction for patients and families, improvement in communication and care, and so certainly some evidence of positive outcomes. But what do we know about advanced care planning and Black patients? It matters. These are data from a national study, and really somehow I think that my arrows got off. They're supposed to be on the green. But the point is that in terms of that no ACP in the green, that non-Hispanic Black patients are almost twice as likely as non-Hispanic white individuals to have no advanced care planning. That's either informal, so talking to family members or clinicians about their preferences or beliefs, as well as formal, completing advanced directive documents. Something certainly that we've emphasized less as an important piece of, advanced care planning as a longitudinal intervention potentially. What about communication? There is a lot about communication outside of serious illness care, and a growing body of research over the last decade looking at disparities in serious illness, in communication within serious illness care. We know that we see these inequities both in terms of verbal communication, with Black patients in some instances having shorter encounters, less likely having communication that would be viewed as emotionally supportive or partnering or even informative with respect to prognosis. And certainly in nonverbal communication, I show some pictures there from a study where Black patients, these are simulated patients, but they had lower nonverbal communication scores, with providers more likely to stand away or not touch patients. We continue to look at this issue, which is an important one. And there, I highlight this study from JAMA Network, published by Crystal Brown and colleagues, looking at a group of Black adults with serious illness, I think around 25. This was a qualitative study asking them about their perspectives of racism, how it's impacted clinician communication. and medical decision making. Certainly, they readily acknowledged, as has been acknowledged in other studies, the presence of discrimination and microaggressions frequently occurring in the clinical encounter, and really focused on one particular aspect of injustice, this idea of epistemic injustice, which has to do with knowing or others seeing you as knowing. They talked a lot about the extent to which providers didn't seem to acknowledge how important their own knowledge of their lived experience as well as their bodies was to thinking about healthcare and medical decision making. There's a lot of literature that looks at, one of the things that we emphasize a lot in palliative care, this idea of shared decision making, showing that shared decision making is of lower quality for Black families and caregivers. I want to highlight one study in particular. This is from one of my mentees, Deepa Shana, recently published this in the JAMA Internal Medicine, looking at shared decision making in the intensive care unit. She used this in this study, audio recorded meetings with clinicians between caregivers who are Black or white in the ICU. And I should note that as I talked about these inequities in communication, we've seen that both by patient report and by analysis of audio recordings. So in this is an analysis of audio recorded encounters, looking at some components of shared decision making. And these were patients who previously and their caregivers participated in a randomized trial of a decision aid for those who are experiencing prolonged mechanical ventilation in different ICUs across the US. And she saw considerable variation in clinician shared decision-making behaviors, those kinds of things that we know are important, providing emotional support, acknowledging trust and gratitude when caregivers in this case express it, disclosing medical information so that patients and families have what they need to make decisions. And really, while there's quite frequently considerable disagreement about treatment preferences, particularly for Black patients who are more likely to want life-prolonging therapies, even in the face of a poor prognosis, one of the most common reasons I seem to get consulted on palliative care, that validating and understanding those preferences is important. And so, what are some of the things that she found in this analysis, which was really outstanding? This is a Black caregiver talking to a clinician and stating, I appreciate what you all are doing. If it weren't for you, he wouldn't be here because you're all making good choices. I have trust in you all, really expressing gratitude to the clinical team. The clinician says, okay. The caregiver says, you're doing a very excellent job. The clinician says, do you have any questions? So really no acknowledgement of this expression of trust and gratitude, which we know is really important to the therapeutic alliance. Well, what do we see similarly if we look at conversations between clinicians and a white caregiver? And I will say, this always comes up, well, what race were the clinicians? You know that the vast majority of ICU clinicians are not Black. So there were, as I recall, no Black ICU clinicians in this study. And we know that Black providers in general make up a very small segment of the physician workforce. So similarly, if you look at a white caregiver, because I'm confident you're going to do everything you can, your very best to get him out of it. Ain't no doubt in my mind about that. And the clinician says, I absolutely will. I'm invested. I'm as hopeful as you guys are. And my goal is to have conditions be as ideal as possible. I think that, this dichotomy is really profound here. The clinician says, okay, really never acknowledges, but here the clinician really takes an opportunity to kind of strengthen that therapeutic alliance, align themselves with the patient and express or the caregiver in this case, and express their commitment to care. Another example, this has to do with the validation of treatment preferences. A Black caregiver says, I don't like what I see now, but I do it because I think that she has a chance to come out of this. She's a fighter. The clinician, how much longer do we try? We're being as aggressive as we can be, but we may be getting to a point where we have to go, okay, what can we do anything else? This certainly sounds familiar. A similar situation where white caregiver expressed their desire for continued life-prolonging therapy. When he was first intubated, he made me promise not to let anybody turn anything off. and the clinician says, I understand your promise to him. We won't leave any stone unturned. Really, again, affirming this commitment to the patient and the caregiver in a way that we don't see in the conversation with the Black caregiver. So, what's another area in the work that we do? There's a lot of discussion about goal concordant care. Does it matter here if we think about race, Black and white in particular? We know that goal concordant care, there's a lot out there about how to measure it and how difficult that might be. I think some of the early work in this space was done as part of the Coping with Cancer study around 2009, 2010, which showed that Black cancer patients, metastatic cancer patients, patients with metastatic cancer, compared to white ones were less likely to receive care consistent with their stated preferences. We wanted to actually look at this in an ongoing large PCORI funded multi-site clinical trial of an advanced care planning intervention in community dwelling older adults with serious illness. And so we wanted to look at both goal concordant care and goal discordant care. And to define those, we used data that we collected based on two questions that were used in the support study. One, what best describes the type of medical care you're getting from doctors now? Two, if you had to make a choice in your current state of health, what would you prefer? And so certainly goal concordant care is if people tell us that they're getting the same type of care that they would prefer, so they would have the same response. And goal discordant care is if they're getting a different type of care than they would prefer. And the two types were either care focused on extending life, even if it means having more pain or discomfort, or care focused on relieving pain or discomfort, even if it means not living as long. And so this is what we found. I think consistent with other studies, you can see that we have over 800 patients, over half of our patients, or around 800, over half of the patients in this study are community dwelling older adults who are Black. What kind of care do you prefer? Black participants were more likely to tell us that they preferred care to extend life. This is consistent with a large body of literature documenting those preferences. When we looked at whether their care was goal concordant and goal discordant, we were both surprised but thrilled, right? Over 3/4 of patients, almost 80%, in each group said yes, they were getting the type of care from their doctors that they preferred. So their care was goal concordant and there was no difference by race. And while we were excited, we know that sometimes when it doesn't seem to matter, that it may still matter. And so we wanted to look at this idea of goal discordant care, right? Because that's the thing I think we'd be most concerned about, that people were not receiving care consistent with their preferences. And here, in fact, we did see statistically significant differences in the pattern of goal discordant care. So if you look in the blue, that's those who preferred, restorative care. They wanted to extend life, but they thought that that wasn't what they were getting. They were getting care to relieve pain, even if it meant that they wouldn't live as long. And you can see over a third of Black patients said that that was true, compared to less than 10% of white patients. So Black patients were more likely to tell us they wanted life prolonging therapies, but that was not what they believed that they were getting from their doctors. While the opposite was true here, over 90% of those white patients who told us that they were getting goal discordant care said they really wanted to focus on pain relief, but somehow they were getting care that was extending their life. And so if you think about, these differences, how does that translate in what we think in terms of patients and our views about their race and their values? So this greater focus on care to relieve pain in people who are really preferring care to extend life among Black patients. Why do these differences exist? And really, what does that say about our approach to care? And then if we think about, those services that improve quality of life for patients and caregivers, specifically hospice and palliative care, what do we know? We probably know more about hospice use than anything else. I've shown this slide for many years, perhaps over a decade now. But what we see here is that if you look over time, this is 2000 to 2022. This is the proportion of Medicare decedents who used hospice prior to death. You see this initial dramatic increase between 2000 and around 2016, and there's a slower increase and some leveling off. And you see an increase for both Blacks and whites. But what you also see is that the gap persists, that you still have a significantly smaller proportion of Black Medicare beneficiaries who access hospice services prior to death. And that's despite what we know is more common diagnoses among those patients in hospice appropriate diagnoses in hospice that are commonly used, diagnoses that are commonly seen in hospice, dementia, heart disease, lung disease, et cetera. What about palliative care consultation? Well, there hasn't been as much, but there has been a growing body, and results are mixed. We know that there is evidence that Black patients may receive care in places that are less likely to have palliative care consultation, particularly inpatient settings like public hospitals, for instance, or even smaller hospitals. There has been work looking at minority serving hospitals or hospitals that have a higher proportion of minority patients, and finding that those are less likely, if you're in those hospitals, that you have a lower odds of receiving palliative care treatment. Other studies have shown that Black patients and also Hispanic patients are less likely to have an inpatient palliative care encounter for a number of things: stroke, cerebral hemorrhage, ovarian cancer, and more recently, a really large analysis of those with end-stage renal disease on dialysis. And then there are other studies where there's been no difference among hospitalized patients. And so certainly it matters sometimes. We also know that other factors have been identified, those that kind of Sean mentioned as also being a part of how we think about inequities: those who have lower socioeconomic status, those who live in certain areas, non-urban areas, for instance, those who are at smaller hospitals, as I noted, those who are at hospitals who have a large proportion of minority patients may be less likely to access or have access to these services or use them. So, this is all about, I've talked a lot about the experience of care. What about intervention? If we think about the ways in which we try to make the experience of serious illness care better, right? We've talked a lot about palliative care interventions. If it's palliative care itself, is it primary palliative care, specialty palliative care, other things that we can do to improve quality of life for patients and caregivers? Does it matter when you get one? So the focus certainly has been on experience and utilization. Can you access the services? But what do we know about intervention in the outcomes and how those might vary by race? So this is from a study that was one of the studies in our first iteration of the Reach Equity. We had 3 R1 level studies that addressed our theme of reducing racial and ethnic disparities by addressing patient-centered care in the clinical encounter. And this is a study that was led by Christopher Cox, who's a pulmonologist and intensivist, and he looked at a primary palliative care intervention in the intensive care unit. We know that Black patients are more likely to have unmet needs in the intensive care unit around communication, satisfaction with care, often conflict with providers. And so in this study, it was a 2-arm cluster randomized trial with randomization at the level of the attending in 6 ICUs and 2 hospitals. You can see the time period. Chris developed a mobile app. And if you're both patients and or caregivers in the intervention and control arm would complete on the app an assessment of their needs. For those in the intervention arm, that was then transmitted to their provider, who was able to then see their needs and receive recommendations on how to address them. And the family members completed the needs assessment at days 1, 3, and 7. You see the eligibility there: patients at a high risk of death or disability. And for the needs assessment, we used the NEST measure, which is this 13 item score 0 to 130 that assesses needs across common palliative care domains. And this was published not long ago in JAMA Network Open. And what you see is it was a positive trial overall. We enrolled 111 dyads, 47 Black and 64 white family members. And by dyads, I mean patients and family members. And the enrollment of Black participants was really intentional. So the goal was to have for each physician 2 Black and 2 white caregivers. And so there was really an intentional focus on oversampling among Black patients to assure adequate power. And so you can see that the dark color is control and the yellow is intervention. But what you can see here is that you have a greater reduction in the NEST score or unmet needs for those in the intervention arm. Hooray. Um, But what about if we looked at these findings by race? So if you look at white participants, this graph is very similar to what I just showed you. You see this clear difference between control and intervention in reduction in these unmet needs over time from baseline to 7 days. You don't see this for Black participants in this study. What you see is actually quite an overlap and a non-significant difference in the two control and intervention in terms of change in unmet needs. And that's because of the fact that what you're seeing here is that Black participants in the intervention and control arm had a similar reduction in unmet needs from baseline to 7 days, something you did not see for white participants. Why is this true? We don't know. So I think, a couple of things we postulated that perhaps because both intervention and control participants were reporting their unmet needs, that Black participants may have been prompted to be more proactive in their communication, having written their needs down regardless of their study arm. They also received question prompts. The other piece, I think, as we think about the intervention is how we think about cultural tailoring. Often we think about that with respect to how patients might receive a particular intervention. But this particular intervention provided the needs to the provider with some standard recommendations, but did not actually provide any other types of tips that really might impact communication differences or inequities that we see by race. And so while they were receiving the information, that same suboptimal quality of communication that we know that exists, likely related to interpersonal bias, stereotyping, interpersonal racism, was not overcome by the intervention. And so as a result, you don't see the same intervention effect. So what if we look at a specialist palliative care intervention? This was the PAL-HF study, which actually was a single site study that took place at Duke. And we enrolled patients with advanced heart failure and a high 6-month mortality in the specialist palliative care intervention that included a certified palliative care nurse practitioner and a hospice and palliative care physician. And patients were enrolled at the time of discharge and as outpatients. And there are 2 measures of quality of life in this study, the KCCQ, which looks specifically at heart failure, and then the FACIT-PAL one, which many people who do palliative care research are familiar with. And you can see that in both cases, there was a statistically significant increase in quality of life in the usual care plus palliative care arm compared to the usual care arm alone. So what if we look at this by race? So we actually did this in a post hoc analysis, and I will say from the beginning that we were not powered to look at racial differences, and that while we saw differences, they didn't reach statistical significance. But I really think that what we found was really important and something to really think about as we think about these interventions. So there you see white patients in usual care, if you look at KCCQ scores, and white in the usual care plus FACIT-PAL. And then the dark is baseline to 6 months. So between baseline and 6 months in the usual care, you see this increase in quality of life scores, 29 points, in fact. And then in the usual care plus palliative care, you see a very similar increase from baseline to 6 months. And so the difference is really very small, 3, because both your control group and your intervention group had similar increases in quality of life over the study period. Let's look at what happens with Black patients. So Black patients actually in the study had higher quality of life at baseline. But if you look here in the usual care, which is the first one there, between baseline and 6 months, you see this increase in quality of life, 9.6. And then if you look in the intervention arm, which included the palliative care, you see an even bigger increase in quality of life, 20, for a difference of 10. And so this really suggests that this addition of a palliative care intervention had a greater impact for Black patients because you didn't see that same increase in both your intervention and control. The same is true when you look at FACIT-PAL scores. I won't actually go through that. I'll just go through that quickly. But here's the summary, and I think it's really important to note. So 0 is the line of no difference between the two arms. And so this is small sample. They both cross 0. But what you can see is that that point estimate for Black patients is in each case well above 0, whereas that for whites is right there at 0. And so this really suggests, could specialist palliative care be more beneficial for Black patients? And why is that true? We saw this similar improvement in quality of life for white patients who received or did not receive palliative care. And so does this really suggest to us that when patients are enrolled in specialist palliative care who are Black, that they're getting something that they don't ordinarily get from their cardiology clinician, whereas that may not be true for white patients? So what about research approaches? We think about health disparities research and how we approach it. Certainly, when I started this work 20 years ago, there was a lot less in serious illness care. I focused largely on hospice. I'm always thrilled because there seems to be a lot more attention to disparities. Certainly, much more work needs to be done. But I'll share this scoping review I recently completed with my colleagues at CAPC. We looked at articles on providing care to Black patients with serious illness. You can see the time period. We identified 160 articles. Even over this time period, hospice patients were still commonly studied. And while we were not interested in intervention, I will say out of that initial 433, only 12% of those studies actually highlighted an intervention or discuss an intervention. So really, speaking to this, that we know that there are lots of articles here, 3/4 of all of the ones here that really focus on the existence of disparities, that there is something different between white patients and Black patients over any number of outcomes. A much smaller proportion of those try to understand why those exist. And then you can see even smaller when you think about intervention research. This just highlights, we wanted to categorize what we study. And if you look through this is a socio-ecological model looking at all of the levels which contribute to health. And you can see that many of the studies were at the level of healthcare system or at the level of individual. And that the majority of those looked at differences in hospice or palliative care use. They're also really interested in utilization of life prolonging therapies, which I think erroneously is often discussed as a quality measure for or described as an inequity for Black patients if they use more life prolonging measures. I mean, I think when you consider the fact that they have lower healthcare costs earlier in the course of illness and life when things are reversible, and more later, whether or not that's the inequity that we need to focus on, I think really brings that into question. And then rates of hospital use again to cost and utilization and advanced care planning. And so overall, this is really limited. We haven't focused a lot on issues around structural racism or policy or the makeup of healthcare systems, or even a lot around these interpersonal interactions that may impact communication and decision making. And I'll say, really to highlight this idea of intervention, this was a systematic review that looked up through 2020 at interventions really to address or improve palliative care outcomes for patients from underrepresented groups. And you can see a really small number of articles included. There are 16, 5 of them in Black patients. And you can see their focus most on advanced care planning, and those really on issues around individual level knowledge, attitudes, beliefs, and self-efficacy. Again, focusing largely on the patient rather than the care setting and providers around them. And then some on peer navigation. So, in thinking about this, I've often heard this idea of admiring the problem, right? We're constantly detecting disparities, not just in our field. If you look across other medical subspecialties, you see a very similar distribution of studies, although they have many more studies. It turns out that this guy, Ashley Brilliant, I found, he's a cartoonist, and he had this. I don't have any solution, but I certainly admire the problem. I don't know that he was the first person to say it, but when I typed it in, it popped up. And I think the other piece that was really interesting is somehow Amazon also popped up. I don't have a solution, but I admire the problem. There's a t-shirt. It comes in multiple colors for those of you who are interested. And I learned that if I ordered it, I could get it in the next 2 days. So just wanted to share that information. So I'm going to actually only mention a couple of things about this next piece because I want to get to the end and to questions. And that's how we think about, I've talked about health disparities research, but how we think about representation and reporting in palliative care research in general. It matters. And I really want to emphasize that it's a both and. We certainly need research to understand inequities in care. And we need to make sure that when we do palliative care research in general, that we're considering the extent to which our enrollment of participants really reflects the patients that we take care of. This was in a systematic review of JPSM articles looking at race and ethnicity and its reporting. We found that most articles reported race and ethnicity, although they used a number of labels, most of them not endorsed by the OMB. And we know that there are recently new guidelines for the reporting of race and ethnicity, really speaking to the issue of standardization. But there were also some other things that we found, right? That 25% really listed in that table one only a white category or white and a non-specific category, non-white or other race, really speaking to how we think about all racial and ethnic groups that we care for and the extent to which we may be normalizing or emphasizing one over the other. There were over 10% of studies that enroll over 90% white participants, very few studies with a focus on minority health and health disparities. And when these things were discussed, inequities in particular, that similar focus on patients' health and cultural beliefs. This shows the mean and median, the proportion of those across studies by race and ethnicity. And you can see that for Black patients, it was about 13% when it was reported, reasonably consistent with their representation in the US population. White patients make up about 60% of the US population and have for this time period, but represent about 74% of participants across those studies. And so I think that there is a real opportunity to look at all of the research we do and think about how we address potentially mitigate inequities or really how we might be perpetuating them unknowingly. So I'm going to make it to the end. So in summary, I just want to highlight it does matter if you're Black or white, whether we like it or not. It matters from birth to death. It matters in the experience of serious illness care. I'm talking about the care experience, the use of evidence-based services, the effectiveness of our interventions, what is studied and how we're represented and reported in terms of enrolling participants. And what do we need to do? I think, simply we have to move beyond admiring the problem. It is absolutely important to name, to identify health disparities and inequities, and we've done a great job. I think we need more research to understand why these exist, and we need to be looking at multiple levels. I think certainly my own research has frequently focused on patients, and I think at times I wonder if we're really thinking about ways to change the patient maybe feels like blaming the patient rather than really looking at the greater systems and interactions that patients have and the extent to which providers and health systems really have a role to play in addressing inequities. We have to start thinking more about testing interventions to address health disparities. They have to be adequately powered and really have to think about the effectiveness of interventions for all groups. They may not be uniformly effective. And finally, as I said, this appropriate representation of historically marginalized populations in all of the work that we do and how we think about that. So I'm going to get back to the king of pop. In preparing for this, I had an opportunity to actually go back and figure out what Michael Jackson was saying. I think I only knew it don't matter if you're black or white. That's the only part of the song that I probably sang to. And this was a description. You can read it here, but it really was about this idea of racial harmony, racial equity, and justice. And part of it really was an expression of his exasperation for racial injustice and his unwillingness to accept it. And you see some of the words there, the things he's tired of. Those are the things that are about injustice, and the things he's not afraid of. And this idea that, it don't matter if you're black or white. But in thinking about that, I thought, well, this probably resonates with me more. I think the idea of racial harmony and equity is aspirational and one that I can certainly get on the bandwagon for. And at the same time, I think of all of the ways that race, among other things, currently matter. And here are some of them that immediately came to mind. That's my daughter in 2020 or 2021 at the Duke Black Lives Matter March. Of course, there's that infamous photo of George Floyd. There's Serena Williams, who's talked openly about her experience giving birth. And then I think as we think about how things have changed in the era of COVID, that's my uncle. And this is an article from Mississippi during the pandemic in 2020, highlighting this greater risk of death among Black Mississippians, of which he was one. And he died about 2 weeks after this article was published from COVID. And so I think I'll end by, acknowledging really that this idea of racial harmony that Michael Jackson talked about is aspirational. And that at the same time, we really have to hold what is current reality. And in so doing, really figure out opportunities to mitigate these inequities and improve equitable care.
Kimberly, thank you so much for a really powerful, informative, and just really terrific talk. We have a couple of questions, some time left, and let me just start with, I think, probably the most straightforward and easiest of the ones I've seen. This comes from Tremaine Cunningham. What specific policy changes or interventions do you believe are most critical addressing the systemic health disparities between populations, and how can these be effectively implemented and sustained? I thought we would just start right there with the most
Well,
straightforward
let's
and
go
easiest
out of the
answer.
gate with the most effective ones. It makes me think about, my mom, and someone she worked with would always say, she said as a physician, and patients would ask him something and he wouldn't know the answer. And he would say, well, if I knew that, then I'd have $1 million. I wouldn't have to work, right? If I knew that, the problem could be solved. I don't know that there is one particular policy change. I don't think, if we think about 400 years of inequity, that it's likely that there is a single policy or a magic wand that'll make things different. What are the things that people are focusing on? So they're focusing on addressing the social drivers of health, right? We see more and more that healthcare systems are saying that, hey, to impact health, we really need to impact all the things outside of health that impact health. I think that that's true for palliative care as well. But I think interventions have to be multi-level. So, that's at a level of policy or health system. But I always think about kind of what are the kinds of interventions that may be useful as we see patients. Maybe that's, training within our palliative care teams, quality improvement initiatives that actually get us to both pay attention to health inequities and investigate the reasons for them. What are the ways in which we really can work to deliver care that's more equitable, rather that's, standardizing ways in which patients are referred or receiving care. So I can't say I have a single answer. I think that it's likely to be multi-level. And I think that I'd just be excited if we tried more things.
Touche. Somebody asked if you have some successful examples of community-based programs that effectively reduce disparities for Black populations, and are there lessons that can be learned from those initiatives?
Yeah, I think when I do, I mean, I personally don't, but when you think about the kinds of things, community level programs that have been most successful, probably most people would point to navigation, right? Starting in cancer care, Harold Freeman in Washington, D.C., really this idea of identifying people who are most at risk to fall through the cracks, going to the places they live to provide services, helping them to navigate our complex healthcare system, and really addressing the needs and barriers that keep them from accessing services that exist.
Thank you. Um, I'll tackle two more. The first from Dr. Noel Marie Javier, who is curious whether there are differences and inequities in healthcare for Black people in the North compared to the South, and do we have any data on that?
That's a really important question. I think that in terms of palliative care, I don't know that studies have addressed this, but we do know that there is regional variation in healthcare quality and also the health quality. So if you look at that health system from the Commonwealth that I showed, you can actually look at many of the southern states where I identified Mississippi. There were some other southern states down there too where those inequities are greater for between Black and white patients than other states. And so there's definitely regional variation by states, by neighborhoods across all kinds of geographic areas.
Actually, I'm going to take two more. One is, were you able to look at race factors on members of the palliative care team members or for volunteers providing care?
Really important question. I think that whenever a lot of what when you look at literature on concordance is what we call it when Black patients are with Black doctors or Black providers. In other areas, there is actually fairly robust evidence that Black patients paired with Black providers have better health outcomes. I think there's some problems with that, right? We don't have enough Black providers to take care of all the Black patients in the setting of palliative care. Certainly, I haven't seen studies that looked at that. I think a particular challenge would be having enough Black providers to look at that. That being said, I will say in some of our hospice work, what we did see was that those hospices that actually did more community outreach within Black communities and as a result had more volunteerism among organizations actually had greater reach into those communities.
Thank you. And then let me give the last word to Dr. Meyer. Um, you know, I fully agree with her. Brilliant as usual talk, Kimberly. She asked if you'd mind talking a little bit about the work that you were doing at CAPC and elsewhere to promote anti-racist work in healthcare and for clinicians. And if I could ask you to finish off on that one, that would be terrific.
Well, great. I don't know if you're exerting any favoritism in your question.
Never, never.
Never. Uh, this is great. I would love to talk about this work. In fact, I always avoid it because I don't want to steal Capsy's thunder and don't know what I'm allowed to say. I think we're going to have another webinar coming up in the fall. But over the last, I don't know, year and a half, I've been working with CAPSI on a curriculum. Many of you may use some of their educational content already to do just that, to really promote anti-racism among palliative care clinicians and teams. And this curriculum will have a number of modules. It will start with the history, right? We really believe you need to understand the context or the construction of race and racism in America. Another will look specifically at health inequities across the lifespan. Another will look, and I think probably one of the most important is really focusing on causes with a particular focus on clinical interactions and unconscious bias, and really ending with interventions. And I think it's really important because this is overwhelming stuff. Kind of what can I do with the patient who's in front of me on my team? And so that last module will have a focus on interventions that teams can use to provide equitable care. So we've been working on it. We actually, I think it's going to be a beautiful curriculum. We'll be talking about it more and hopefully in the next, I don't know, I don't want to say time because I don't know, really unveiling the curriculum, but certainly having the opportunity to have pieces in between. I think another big piece of this that we've tried to weave in is stories. And I'll say that I always share something personal. I shared it at the end. And the reason is really, I think we have to remember, as I spout out a whole bunch of numbers and studies, that they're real people with real experiences behind the work that we do.
Kimberly, thank you so, so much for really an incredible talk. And I think I'm echoing a lot of what I've seen in the chat and text messages that I've gotten. We couldn't have asked for um, really a more illuminating and thought-provoking presentation over the past hour. Thank you so much for spending time with us. Recover well. For those of you, I will just say that Dr. Johnson um,
Recovered
is
from COVID.
recovering from COVID, and quite a remarkable performance given how she's been feeling the past couple of days. So, Kimberly, thank you so, so much. Look forward to seeing all of you next year for the West lecture. For those of you who have requested Dr. Johnson's slides, I'm going to talk to her afterwards, and we can see about perhaps distributing, but I need to talk to her about that first. And Kimberly, I look forward to seeing you in 3D in the not too distant future. Thank you again.
Yes,
Thank you all for
I'll be
joining
COVID free then, I promise.
me. Thank
It's
you
a
again,
good thing
everybody.
this was virtual or I wouldn't have made it.
Thank you,
uh,
everybody, so much.
bye,
Have a
everybody.
great night,
Have a good
everyone.
evening and enjoy your dinner.